Hello, I'm Dr. Jonathan Levine, host of Case Bites, where we unravel the complexities in dentistry from simple to complex cases from a treatment planning case presentation standpoint. Let's get started. I am joined by the periodontist John Kim out of Rocky Mount, North Carolina. Alan Jerem, a specialist in digital dentistry, runs that department at Toro. Amazing friend and colleague, and all of these people are just very special. Rick Robley out of Fayetteville, Arkansas, who wrote the book on interdisciplinary dentistry. I'm going to bring him back to 1996, I believe. Stanislav Mishi, prosthodontist, runs the program at Boston University, and myself. Well, let me start by bringing a case to you that I did 3 decades ago. 30 years ago, and show you how we thought about our cases that long ago when we didn't have digital dentistry. So meet Bruce. And back then, we still had the notion of the aesthetic evaluation form for sure. But this sequence is what we're presenting, where we look at the chief complaint, medical history, go through the aesthetic evaluation form, then go through all of the structure, function, and biology, perio, and then the ability to visualize. So we're going to talk plenty about this. The chief complaint Bruce came up with that he's wearing down the edges of his teeth and they're disappearing. They're getting worn down and his jaw is not comfortable. He doesn't know where to bite. So I would always ask a question to understand the mindset of the patient as we think about changing the smile. Do you like the image of straight, white, perfect, or clean, healthy, natural? And that is 2 very ends of the spectrum. Clean, healthy, natural being those perfect imperfections. Well, he said clean, healthy, and natural. Medical history, non-contributory, 30-year-old male, 30 years ago. His dental history, he had orthodontics, premolar extraction in the upper jaw only. History of grinding teeth, a lot of wear on his front teeth. Very unstable posterior occlusion, periodontal status healthy. So back 30 years ago, we still took this systematic approach, identified the problem using these 3 steps, and then visualize where we want to go, and then always choose the appropriate technique, which is the conservative technique. Same thinking today, same thinking back then. So this systematic approach applies a 3-step analysis. So we use this aesthetic evaluation form. We use a diagnostic wax up. Today, we do a lot of digital smile design, but we want to visualize where we want to go and then work backwards, coming up with the technique. And of course, we want to show the patient. So we like to use the motivational mock-up. In looking at the aesthetic evaluation form, we go through, here's a facial analysis of Bruce. And so interpupillary, we look at it to the commissural line, the midline. We see if there's any canting of the maxilla. Where's the midline, right of center, left of center? What's the symmetry like in the upper right lip, upper left lip, or any canting? And we look at, of course, lip at rest. It ages the patient. He's actually hiking the lip up a little bit, and he showed really 0 with the lip at rest. Upper lip is thin, and we look at kind of lip posture back then, kind of same what we do now. This profile view, really interesting, the concept of facially generated treatment planning. I remember being at the Academy of Aesthetic meetings in the mid-90s and Lloyd Miller presenting this, and where you have a concave profile, lips way set in. He's got 8 millimeters, 4 millimeters in the lower lip, very concave, and that talks about building things out from a tooth position. So that's how we start visualizing concave profile. How do we make teeth bigger, but also tooth positional changes, or even bone changes. So when we take a good look, so Bruce had, to my amazement, premolars taken out on the upper, no premolars on the lower. And if we take a good look, if I'm looking at the posteriors, we see kind of a lack of these posterior verticalizing contacts and a lot of incisal edge wear. And we know that happens without those posterior contacts. You get this mandibular postural change, and you get an auto rotation of the mandible. They try to find
contact anteriorly, and there's all that wear happening. And that's what happened with Bruce. And we think about the neutral zone oral pounds thinking and biological width from Bob Lee, overbite over jet. But this whole dynamic system is now thrown off because of the lack of posterior contacts and the wear on the anterior teeth, and you don't have the overbite overjet for coupling. So as we're looking at this and we're saying, well, how do we restore? We got to bring back that edge to get that proper lip posture. So without the edge, the lips fall in, and with the edge, the lips evert out and are supported. And that's the thinking here, both from a functional aesthetic change, and that's where we link that up as we look at the overbite overjet tooth position. And we know, we're looking, and we palpated the muscles and made sure that there wasn't TMJ problems, NPD. But basically, it's a condyle disc assembly, properly placed, and that he was okay there. However, lack of coupling and lack of these posterior contacts, as in number 3, you need that 1, 2, 3. So we visualize, and we want to then take proper records. And when we take proper records, we got to create space. And so right before first tooth contact, and we use a Lucia jig, and then we register posteriorly and diagnostic wax up from there to visualize, identify, and visualize using the 3-step analysis of aesthetic eval form, diagnostic wax up. And then we look to mock this up in a patient's mouth. But there, the right side and the left side, back then we did analog, of course, and we waxed up posteriorly and try to get those contacts. And sure enough, we were able to get some overbite overjet. And there's the upper, there's the lower. One of the technicians at the time did that. And then we want to show the patient. So back then we did a little computer imaging to show the patient. But the diagnostics was clear. When we waxed it up, we realized we had to restore all the posterior teeth and restore the anteriors, not just one arch, but really both arches. It became really clearly explained. And there we are developing, proper posterior contacts. These are provisionals, and this is 30 years ago, and these are the preps, ceramo metal. And here's the right side, and there is the cusp fossa relationships posterior. There's the overjet that looked a lot like our provisionals, and there's the left side, getting rid of that teeter-totter posterior contact and really develop cusp fossa relationships. Lower anteriors we're able to do with veneers. These beautiful ceramics by a ceramist named Naoki Yaiba I was working with back then, and beautiful incisal edge. But you can see the ceramo metal margins, and he didn't show it and have a high smile line, and we got away with that. But what's interesting about this case is, really looking at the material we used back then, ceramo metal, nothing all ceramic. But look at the dynamic change of the smile. He looks, much younger. He's got proper lip posture. And we see this all the time when you're bringing back the incisal edge, where you're getting proper lip support, and the proprioception is working so well to bring back people. Well, let's fast forward 30 years. And here's Bruce, a little bit gray hair, but there he is with the same reconstruction. Very interesting to see. There's the overbite overjet, a little bit of wear at the incisal edge, a little bit of recession, so gingival margins are showing. But sure enough, fantastic coming in. Always looking at the coupling and right working, left working. You see some wear, a little bit of a grind problem, but we always finish with night guards, constantly adjusting occlusion, making sure that our contacts are not in hyperocclusion, holding 7-micron foil everywhere. And then, of course, always night guards, adjusting night guards every time they're coming in for hygiene. So that's a look back 30 years. I wanted to go over just to show a little bit of the process. Even 30 years ago, didn't have all of the beauty of the digital workflow. But what's interesting is the fundamentals stay the same. They really do. And we always say digital dentistry won't make you a great dentist. We have to really understand the fundamentals. So I'm going to stop now, and I want to bring in our tremendous team, Dr. John Kim, Dr. Alan Jerem, Dr. Rick Robley, and Dr. Stanislava Mishi. Thank you.
Thank you for presenting that excellent case. It just shows how well the treatment holds up over time. And this is something that we were able to fast forward 30 years and sort of see where things stand. And as a periodontist, I'm going to focus on the tissue, of course. And overall, the periodontal health seemed to be pretty good. Seemed like the patient had a good band of keratinized tissue. and all but maybe the mandibular premolar, if I can remember correctly, it might have been number 21 and number 12, and maybe a lack of attached gingiva. So back then, as a periodontist, or if I was treating this 30 years ago, I would have been wondering, well, do we do a graft here or not? I mean, if the patient's not bothered by the aesthetics or is not having any sensitivity symptoms at all, and then the question I ask myself as a periodontist is, with the lack of adequate attached gingiva, do I provide some more attachment to that area? Do I do a free gingival graft? Do I do a connective tissue graft? And so I think in the latest World Workshop meeting, I think it was in 2017 or 2019, they say that if the patient has good oral hygiene and there's not going to be major restorative work or orthodontic work done, you could go with that minimum keratinized tissue, maybe a 2 millimeter band of 1 millimeter attached gingiva, and likely it will not recede. It's not a guarantee that that will not happen, but it's just sort of a guideline we use. And so I don't know. I mean, I never feel like I can make the correct decision on these, and I just try to go by the numbers and the guidelines and the recommendations. And perhaps maybe 30 years ago, I would have recommended a connective tissue graft in the premolar areas. But looking at where this case is now, there's minimal increase in recession. And so it always makes me wonder, what's the best thing to do for our patients? The little recession this patient did have an increase in is not the biggest deal, because us as periodontists, we could catch up and correct that still now. And I would probably still at this stage just keep a watch on it unless the patient does not like the way it looks or if it is causing some sensitivity issue.
Right. Yes. I think the key and why this is so interesting, I want everybody to weigh in, as a restorative dentist, where do we put the margin? And where we put the margin in that case 30 years ago was same thinking, equigingival. I learned from really super talented people, and we learned equigingival. There's no reason to go subgingival. So if we need to graft, we could always graft. So we're either going equi or somewhat super gingival. But I will tell you about that case. 30 years later, he's still probing 3 millimeters, still, great periodontal health. But his home care is great, and his compliance to be in 3 to 4 times a year. He made the investment in his teeth years ago, and he's on top of it. He always wears his night guard. So he's an ideal patient to show 30 years later.
I think the case is wonderful because from the perspective of seeing it and seeing the steps that you went through in a truly analog fashion, right? Analog and digital basically should lead to the same result. They're a tool that's necessary for the dentistry. And seeing how that was applied 30 years ago, and how, the case I'm going to show is a similar style case, and how we manage the occlusion, how we manage the aesthetics, and how we manage the complications that led to the patient getting there. But the techniques are different, the tools are different, but we're trying to achieve the same exact result. It's beautiful to see how you can look 30 years into the past, or even 30 years in the future, and see how, if you understand to manage the dentistry, the patient, the results are going to be there. It's really great to see. I love being able to see cases in the future, which I don't have the opportunity of seeing so much. I've been seeing cases that we've done for, 10 years in our practice, and seeing how you can manage the occlusion, I think, is also a really big step in why that patient was so successful 30 years later with the materials, is managing the occlusion was a big part of it.
Yes.
It is definitely very, very humbling to see a case 30 years later and to see it in a completely analog way. And then Alan is going to show us some complete digital cases. And I guess some of us are in the hybrid dentist era, where we have seen analog, we have seen digital now. Everything is developing so fast, and it's fascinating. But as Dr. Levine explained, following all the parameters, it just ensures that stability long-term. So that is the most important part that he demonstrates to us once again, just following the basics, following what we learn, following the parameters, and not violating any of the rules we have been taught. Thank you, Dr. Levine. Wonderful case.
Jonathan, that was a great case, and you're talking my language. I love the history of interdisciplinary therapy, and I think it's an incredible message for the young and vibrant people who are coming out with all this information about digital technology to be able to see where it all came from in the analog world. To be truly a master of digital technology, you have to understand and appreciate the analog world. And I think that's critically important. And, I'm glad you showed that. And next time I'm going to take that and show some great analog cases to historical, but my compliments to that case and the longevity. That's where the rubber meets the road. Thank you, sir.
I mean, I'm humbled by everybody's comments, but for us that have been practicing that long in 3 decades, we stand on the shoulders of the people who taught us fundamentals of aesthetics, occlusion.
Absolutely.
Pete Dawson, Panky Man, Schuyler, Rufinock, Sheesh, the whole team, the Nathologists, the Franks and Lenses. And, these people taught us posterior verticalizing contacts and anterior coupling. The rules are the same. If we do it in Emacs or zirconium, we design digitally, we CAD CAM and layer, but it's the same. And I must tell you, every now and then, I kind of wish I was back in my ceramo metal days. The predictability of it is so incredibly high, especially on these implant cases. But we can get into that another time. But fantastic. Round it all out. So 30-year-old case, fundamentals remain the same. I think that is the message from the 5 of us. And we layer on the new technology that absolutely makes us more efficient, and we can be more effective, and we can create natural tooth forms. And there's some great advantages. But we cannot forget what got us here, which is the fundamentals. All right, that's a wrap, everybody. That's Case Bites. That's his first episode, and we'll see you real soon.
Thank you for joining us for Case Bites. If you haven't already, please subscribe to this series to receive a new case in your inbox every week.